Over to our topic for tonight. We were talking about current concepts in the management of hip and knee osteoarthritis, something that obviously is very close to my heart and something which I've dedicated my life to. And I just want to thank Amr Al-Qadi and Standard Bank for sponsoring this. I'd like to also thank Dr. Buru for chairing this meeting. And most of all, I'd like to thank all of you for taking time off your busy practices, busy days, and to listen to some of my thoughts. And I'm hoping also to even, hopefully that you would share some information with me and share your thoughts and experiences as well, so we can learn together. And preparing this talk, I tried to sum everything up in one quote. So, we do what most of us do when you want to post something on Instagram. We sit and we look for memes and pictures. And I came across this quote from Moshe Feldenkrais. And it says, movement is life. And without movement, life is unthinkable. And this, having spent now a good number of years and a good volume of cases, treating patients with joint disease, doing joint reconstructions and arthroplasties, you really see the difference in the quality of patients' lives, the emotional state, the overall social state, etc., through treatment of the arthritis, through arthroplasty, whatever means we go to try and achieve this. And it's very rewarding, and it's really what drives us to do what we do. So I'd like to just start off with that. And when we talk about arthritis, we're not just talking about a joint. We're talking about a human being and their ability to move. And the ability to move is what makes us alive and what gives us life. So osteoarthritis, definitely the leading cause of musculoskeletal disease worldwide. And we know from modeling in the US, in Canada, in Europe, as well as in Australia, where we have these big registries of patients, we know that the prevalence of osteoarthritis is expected to increase substantially. Not only that, we have younger and younger patients presenting with osteoarthritis for various reasons. And also with recent advances, which we'll discuss a bit later in arthroplasty, we have a much younger demographic of patients who are becoming candidates for surgery, whereas 20 years ago, these patients were refused surgery. And interesting enough, in terms of looking at disability, osteoarthritis ranks very high up in terms of that. And only trails cardiovascular, cerebrovascular, and pulmonary disease in terms of disability for patients older than 65. Also, just bear in mind that 65 years is something that's sort of, from other countries. And my sort of experience and experience of, many other surgeons will tell you that our average age of patients who undergo surgery for arthritis is generally a lot younger. There are many reasons for that, such as trauma, etc., HIV, but we tend to treat a lot younger patients as well. And it's also one of the top 10 causes of years lost to disability. And this is across the board for low, middle, as well as high income countries. So just setting the scene, and it's important that we also just remember that today is World Arthritis Day. And it's great that we get to discuss this topic, and I get to share some of my thoughts of, something that I really love and enjoy with you. So we've discussed some numbers, and we recognize that osteoarthritis is going to be a serious problem in the future. And there's a shift towards us as health professionals to be more involved, either in public or in private, in the systems that we work in, and be cost conscious. So when we look at the numbers that's projected for osteoarthritis, we know that there's going to be some significant costs coming our way if they're not already.
But I gave Aaron a check that not pricey. So I added another 2 children.
Yeah. So just looking at some papers I've been looking at. So this is published in Australia. As I mentioned, these countries have quite large registries for us to work from. South Africa, we're still in the sort of, the beginning phases of starting a proper joint registry. So hopefully in 10 to 20 years time, we'll have this type of data as well. But they're looking at the incidence of total knee arthroplasty and total hip arthroplasty. And this is just for osteoarthritis, bearing in mind that South Africa, our demographic or our prevalence, our spectrum of disease is slightly different because we have the added trauma, HIV, and ARVs and their effects on the hips and knees. it's expected to rise by almost 3 times, 276% for knees and 208% for hips by 2030. And this is a cost of $5.32 billion to the Australian health system. If you look at the US, so the more joint replacements we do, just in terms of numbers, we're going to have more complications, right? And this is just an accepted part of surgery, that we will have complications, right? And the most dreaded complication for all of us, especially arthroplasty surgeons, is the risk of periprosthetic joint infection. So in the US, this is a very recent paper from May this year. They looked at the combined annual hospital costs related to periprosthetic joint infection of the knee. And that's estimated $1.85 billion by 2030. And so this is, like I said, this is mainly attributed to volume. So these are some big numbers we're talking about, just arthritis and joint replacement. The next thing I just briefly want to discuss is arthritis, cardiovascular disease, and diabetes, and even death. Now, you're probably thinking, why is this orthopedic surgeon talking about cardiovascular disease and diabetes, right? I've heard all the jokes, and I probably tell them very often myself. And we all know about the double-blind study of 2 surgeons looking at an ECG. But I think that notion is changing. The more that we treat arthritic patients, the more we begin to understand these patients as holistic human beings, and how the body is an interconnected link, and how a link in something musculoskeletal can actually have far-reaching effects for these patients. So this is a study so out of Canada. So just to understand, Canada has what we would term a national health insurance. So each province has a health or medical aid, or what they call a insurance plan for the population. So each doctor has to bill through that medical aid. So it's very easy for them to collect large pieces of data. So Dr. Ravi is one of my supervisors at Sunnybrook in Canada, and I worked on some papers with him. This is one of the papers he published a bit earlier. But this was looking at the all-cause mortality and serious cardiovascular events in people with hip and knee arthritis. Right? And looking at individuals with hip and knee arthritis, they found that the severity of osteoarthritis disability was associated with a significant increase in all-cause mortality and serious cardiovascular events after controlling for multiple co-founders, which means that they took all these multiple co-founders and they have various mechanisms which to neutralize them, and still find that osteoarthritis leads to serious cardiovascular, cerebral vascular events. This is another paper. This is out of UK. And they said the data available today also indicate that osteoarthritis may be considered as the indirect cause of cardiovascular disease. And they believe that this is in part by increasing the walking disability and the use of analgesic medications such as non-steroidal anti-inflammatories. So here again, we're finding a link between osteoarthritis and heart disease, so heart attacks, etc. Now looking at diabetes. Now, this is also another study by Professor Ravi, looking at walking difficulty from osteoarthritis and risk for diabetes complications. Right? In this study, they found that there was a significant and potential modifiable risk factor for diabetes complications, which is osteoarthritis, because we know that it can be a modifiable risk factor. We can treat it, right? So the longer patients live with osteoarthritis, the longer they have this pain and this inflammation and this walking disability, the more chance that their diabetes is going to complicate. And we tend to think that, oh, because the patient is diabetic, or because the patient is hypertensive, because the patient is heart disease, maybe they're not a candidate for surgery. And that paradigm needs to change, in the sense that we are treating the heart disease, we are treating the diabetes, we are treating the patient by treating the arthritis, we are treating the patient as a whole. And this is another study looking at also diabetes, and they say the data suggests that people with both diabetes and osteoarthritis, the arthritis increased walking disability and grip strength, and increased the risk for serious diabetes complication. And they're basically saying that in patients with diabetes, we need to improve our detection and management for osteoarthritis, particularly in the diabetic population. And this is, what we were talking about earlier. Again, also the link between arthroplasty or joint replacement and cardiovascular disease. the study actually found a cardioprotective benefit of primary elective total joint arthroplasty. And I think this is quite a big thing in the sense that we can show that, by performing an arthroplasty on a patient, by giving them that movement, by giving them that new lease on life, we're actually protecting them, and we're also protecting the health system from further costs. And then I found this website, which made me very happy, and they very beautifully illustrated the relationship between joint pain, which leads to limited mobility, decreases your physical activity, leads to obesity, increased pressure in your joints, and this vicious sort of cycle. And associated with it on the side, you see there's heart disease, type 2 diabetes, and depression. So the focus is really changing from this being a purely joint disease and transforming more to a systemic disease that affects all aspects of a patient's life, particularly patients with diabetes, hypertension, heart disease, cerebral vascular disease. Osteoarthritis can be the difference between life and death to some degree. This was quite also a disturbing paper from the UK. Similar to South Africa, they have a public health system as well. And we all know with public health systems, waiting lists for joint replacements can range between anything between 2 and 5 years. And working in many of these units, it's actually quite heartbreaking, actually sometimes calling patients for surgery waiting for 5 years only to find that some of them have died from heart disease, from cerebral vascular, whatever the case may be. But they found that in alive patients, right, using the EQ5 quality of life scoring system, they found 19% of patients waiting for total knee arthroplasty and 12% of patients waiting for knee arthroplasty for degenerative joint disease are in a state that's worse than death. So basically, their health scores are worse than a dead person. And they said even though comorbidities contribute to this, the lack of hip and knee function and mainly pain that these patients are experiencing all the time are the key determinants. And this can easily be reversed with an arthroplasty or joint replacement. And to quote, very popular bodybuilder, and just tying in with the previous study, life is movement. Once you stop moving, you're dead. So let's choose life, and let's choose to help our patients, not just in their joint pain, but also in terms of prolonging the quality and duration of life. So basically, in summary, the burden of OA is growing rapidly. And as osteoarthritis grows, we also have the need for total joint arthroplasty. It has major economic implications. Whether it's treated or untreated, it has serious implications. So we treat these patients, it's a cost to the system. We don't treat them, it's a cost in terms of managing their comorbidities. So untreated has serious consequences, even worse than death, and severe loss in quality of life and of life itself. And orthopedic surgeons, we do look mostly at the bone, but we don't just look at the bone only. We are starting to look at the rest of the patient as well. So into more of the nitty-gritties, just the anatomy of cartilage, which covers our joints. We have different zones to the cartilage, and then we have the subchondral bone and the cancellous bone. And the disease of osteoarthritis predominantly first affects the cartilage, and then as the disease progresses, starts affecting the bone and the subchondral bone, and then eventually patients present with bone loss. This is a very long-winded, sort of comprehensive definition of osteoarthritis, which they tried to develop in 1994. But the important things I've underlined is it's a mechanical and biologic event. So it's not just overuse. It's also biological events that we are still working on a molecular level to try and figure out why patients have osteoarthritis. There can be multiple factors, including trauma and genetic factors, but they all lead to the same sort of pathway, and they don't just involve the cartilage, but they involve all tissues of the diarthrodial joint. So not just the cartilage, but also the ligaments within the joint, etc. And once you have lost articular cartilage, you have damage to the bone. This leads to joint pain and limitation of motion. So basically, to summarize, is what I like to term the osteoarthritic cascade is irreversible damage to the cartilage, then damage to the bone, leading to joint dysfunction, deformity, decreased range of motion, and pain, right? So let's just kind of keep it in mind, this term, the osteoarthritic cascade, right? So it got me thinking, right? So we can't really sort of modify the biological environment just yet, but we can definitely alter the mechanical environment. Because at the end of the day, what's an orthopedic surgeon? He's a mechanic, right? So I started looking at, and it's also being, being inspired by other people as to how we're going to stem the tide of the pandemic or that's coming, right? So how do we halt it, right? And I mentioned this before. And so how can we influence the mechanical factors, right? So the rest of the talk is going to follow this outline. I'm going to look at hip and then knee and then some recent advances. And in part two, I'll just cover some of the more, sort of what we call the cutting edge aspects of arthroplasty, the modern approaches to how we approach joint replacement, especially when doing big volumes in hospitals. So looking at hip osteoarthritis and halting the cascade by early identification of predisposing conditions. I'm going to cover two specific conditions. And what really sort of inspired me was a talk by the old gentleman, the shorter one on the left, and that's Joseph Schatzker. So most of us who went through medical school, we remember the Schatzker classification of tibial plateau fractures. So we had the pleasure of working alongside him to some degree, although he was a bit sheltered because of COVID, didn't want to get him out of the house much. He did give us a number of talks and shared us out his views on what he termed the continuum of arthritis care. And he gave us a talk at our research day called Joint Preservation in the Continuum of Arthritis Care. So what he essentially was saying is that arthritis care doesn't only involve joint replacement, doesn't only involve once a patient has florid disease of the joint and they've got joint dysfunction. Arthritis care starts before the joint actually degenerates by identifying certain conditions which can predispose to osteoarthritis. And this was very personal for him because he has a genetic condition in his family where they have a certain condition I'm going to discuss now called femoral acetabular impingement. And all of his sons, not all of them, but some of them already have been for surgery to try and correct this and hopefully prevent osteoarthritis. So for him, it was a very personal thing. And for him, he really inspired us by giving us this exposure. And it also took me back to my time at Chris Hani Baragwanath, Professor Bloomson in the medical department. And he always told us one thing: you find only what you look for and you recognize only what you know. So know a lot. And how I related it to this specific situation is that we look at hip and knee x-rays every day, right? But I think for many, many years, the things have been staring us in the face, and we've only really begun to understand these things recently. So, and I think most of us still look at x-rays and we still don't recognize certain things. I think with time, we're going to understand it, but more. But hopefully, if we just sort of look out for a few important things and sort of red flags, we can recognize patients who are on that way to developing early osteoarthritis and hopefully try and stem the tide and prevent that cascade. So the current trend, like as I mentioned before, is on prevention, right? We want to address factors which predispose to labral cartilage damage. And the two conditions which I'm going to cover is femoral acetabular impingement and hip dysplasia, and how we can halt the osteoarthritic cascade. I'm not sure who wrote on my screen there. It wasn't me. And just in terms of what dysplasia and femoral acetabular impingement is, dysplasia on the one hand is a static disease, and I'll explain that now. Femoral acetabular impingement is a dynamic disease in the sense that it only really comes into play during motion of the hip, whereas dysplasia can affect the hip even without excessive motion. But essentially, the pathway which they both leads to the osteoarthritic cascade, right? So what is femoral acetabular impingement? So it's a group of femoral and acetabular deformities when combined with hip motion, such as flexion and rotation, lead to impingement on the acetabularum complex and then leads to chondrolabral disease, right? So just bear with me for a second. So firstly, this is the femoral deformity. It's what's called a CAM deformity, right? And this is basically means there's insufficient offset or clearance when the femoral head moves around the acetabulum. Why? Because the head becomes aspherical and there's a little bump at the head and neck junction. Whenever that bump touches the acetabulum, it leads to labral or cartilage injury. And with time, that leads to osteoarthritis. The pincer, on the other hand, is a pathology on the acetabular side. So much like the CAM lesion, it only comes into play once the neck of the acetabulum, once the neck of the femur impinges on the acetabulum. And this is what's called acetabular overcoverage. And there's various mechanisms where this can happen, either pure pincer or a retroverted acetabulum, or very deep set femoral head, what we call protrusio, where it's so deep into the acetabulum that it impinges on the neck. This leads to less cartilage injury, predominantly labral injury, but definitely still part of the same pathology of femoral acetabular impingement. So this is just an illustration. On the left, you have an X-ray, which shows both a cam and a pincer lesion, right? And then on the right, you have an open hip dislocation where they're addressing these pathologies, right? I think so. Here you can very nicely see exactly how these pathologies present. This is just another X-ray of a 29-year-old female, very active, came presenting with hip pain. And you can see here as well, very, very clearly this cam lesion and pincer lesion, both on the left and on the right. And if you draw the lateral center edge angle, which is normally, much less than 40, probably about 35 or so, you can recognize that there's definitely some acetabular overcoverage. And how this patient presented was that they were very active, and because they had super physiological ranges of motion, they tend to develop this disease. Unfortunately for this patient, you can already see they've got degenerative joint disease, so options of joint preservation sort of not possible at this point in time. But hopefully with time, we'll all start to recognize these patients earlier and get them to the right care. Because this is an X-ray of a 50-year-old male with severe destruction of his hips bilaterally. And what you can also recognize is that he's got a very retroverted acetabulum. So our thoughts were that, because he had such a retroverted acetabulum, he just impinged very badly and developed severe osteoarthritis. Now, when you think of hips like this in a 50-year-old, you automatically have to think of something other than primary osteoarthritis, because young patients like this shouldn't present with such bad hips. And this is what we're trying to prevent. We're trying to prevent patients coming in with such bad hips at such young ages. So there's multiple risk factors. So like I said before, it is a dynamic deformity. So there's probably a lot of patients out there who have these deformities, but then don't develop the disease, or they don't develop osteoarthritis because maybe they're just not as active, right? But we have noticed that in certain groups of patients, such as dancers, hurdlers, they do develop these deformities, the femoral acetabular impingement, but we're not 100% sure whether one develops before the other, right? But our thoughts are that, the impingement first. And there's also other proximal femoral and acetabular deformities that can lead to this. So importantly, how do we pick it up, right? So generally, these are younger patients as opposed to older patients. And they typically present with what's called a C sign. So they'll cup their hands around the groin area. And that should really alarm you to a pathology in the hip. Generally, hip pathology is localized to the groin. When it's localized to the lateral aspect of the hip or the posterior aspect, you usually need to think about greater trochanteric conditions or nerve impingement if it's coming from the back of the hip. The impingement test, or the fader test, as it's called, is when you flexed AD duct and internally rotate the hip. And if you think about the deformity, the cam and the vision, you're basically trying to stimulate that impingement. And if the patient has a positive sign, then that generally suggests that there could be impingement in the hip. It can be other pathologies, but generally in a young patient with hip pain, you should try and do an impingement test and try and see if they have this. And what I found is that sometimes you need to do the test 3 or 4 times just to irritate it a bit to see if it's positive, or sometimes it may not be positive in the first time. So the treatment essentially is first early detection. You want to detect these patients before they develop osteoarthritic changes. So you need to have a high index of suspicion. It's very suspicious in young patients with hip pain. And the typical sort of presentation is the groin sprain, which is not responding to physiotherapists. So I think, both, in general practice or physiotherapists and even specialists will come across these patients. Just need to be just a little bit more vigilant as to how we treat the typical groin sprains. And sometimes just a simple X-ray will lead you in the right direction. And in terms of management, usually we start with an MRI because we need to assess whether the joint is still viable or not. The moment, like I said, there's cartilage damage, the chances of retaining the joint become a lot less. And there's various arthroscopic options as well as open options in terms of surgery to address these lesions, either the CAM lesion or the pencil lesion, and remove that impingement and hopefully halt the osteoarthritic cascade. The other thing that can lead to hip arthritis, especially in a young patient, we're fortunate in South Africa in the sense that we have very good screening for hip dysplasia in neonates, so we don't see it as badly as some of my colleagues in Saudi Arabia and Turkey who tend to see it a lot more than we do. But essentially, when we talk about dysplasia, we mean that the acetabular side is dysplastic in the sense that it doesn't cover the entire head of the femur. And because it doesn't cover the entire head of the femur, you have abnormal contact forces at the superior aspect, and that leads to early degeneration of the cartilage. So it's a spectrum of disease from the version of the acetabulum, how antiverted or retroverted it is, the depth, so how far the head goes in, how much coverage it has, and it's also associated with some femoral deformities, and these leads to alteration in the biomechanics and in pathological states. And as I mentioned before, you have these deformities, and this leads to rim loading, and then joint reaction forces, and then the articular damage. So how do you detect it, right? So the easiest way to detect it is to look at your lateral center edge angle of Weiberg, right? So how you do this is that, I think a lot of the PACS software will allow you to do this. So it becomes a lot easier nowadays. So you take the femoral head and you take the center point and you draw a line perpendicular up from the ischial tuberosity. So basically perpendicular up, and then from that same point to the lateral edge of the acetabulum. So normally it should be between 25 and 39. And then if the patient is between 20 and 25, we say they have borderline dysplasia. And if they're less than 20, we say they have definitive dysplasia, which usually requires some sort of intervention from the surgical side. The other one is the tonus angle. If you look at the acetabular teardrop, we draw a line perpendicular to the line drawn between the two ischiums, and then from the edge of the eyebrow to the edge of the acetabulum, and that should normally be less than 10 degrees. The moment it goes to more than 10 degrees, that's indicative of dysplasia. And then you can do MRIs and CT scan here again. The CT will give you a better idea of the morphology, and the MRI will give you a better idea of what's the quality of the cartilage, what's the quality of the labrum, and if there's any chondral lesions, is the joint still amenable to joint preservation. We don't have much knowledge about the natural history if we don't treat them, because we generally want to treat them early. But in patients with mild symptoms, very little deformity, and no contraindications, we can try and treat them non-operatively. Some things you can do is to modify activity, one sort of anti-inflammatories, intra-articular steroids, I think we're all familiar with in terms of treating osteoarthritis. And here again, the physiotherapists can assist in any abductor strengthening, just to keep that hip inside the socket as much as we can, because that's what our abductor muscles do, and core strengthening, and then also avoidance of any exercises or positions which may increase the stress at the hip. Operatively, it's quite a demanding operation. It's called a periacetabular osteotomy. And basically, you do cuts through the ilium, the ischium, and the pubis, and you literally just twist that segment around to get increased coverage of your acetabulum. It's a very demanding operation. I think in South Africa, we only do about 6 a year. Like I said, we've got very good screening for dysplasia from a young age, so we don't tend to see as many of these patients later on in life, fortunately. However, we still do see patients who sort of missed the boat and then require arthroplasty. So arthroplasty in a patient with dysplasia can be a bit different from your typical osteoarthritic patient. So like I mentioned before, these are different but similar. they're on the same sort of spectrum. One is static and one is a dynamic deformity. And all lead to the same thing we talked about earlier, the osteoarthritic cascade. So preventing hip osteoarthritis, we need to try and keep these two conditions in mind when we see patients, especially young patients. And we need to maintain a high index of suspicion and try and pick up these conditions early. The next thing I want to talk about is the treatment of hip osteoarthritis. So we generally take our guidance from the AOS clinical practice guidelines, which are published every couple of years. And when you're approaching osteoarthritis, there's always the non-surgical and the surgical options. And we generally look at them as a ladder, from surgical up to non-surgical up to surgical options. And we will run through some of these now, right? So weight loss and exercise is always the first line for any patient. And this weight loss improves functional outcomes and pain scores for both hip and knee osteoarthritis, but more pronounced in knee osteoarthritis. Not only that, weight loss can also decrease your risk of complications should the patient undergo a joint replacement in the future. We know that for hip patients with a BMI of above 30, that the risk of complications significantly increases. And for knee replacement patients with a BMI of 35 and above, their risk of complications significantly increases. I always refer patients to a physiotherapist very early because we need to maintain the conditioning of the muscles. With pain, patients tend to become less active, and when they become less active, the muscles become deconditioned, and then the outcomes of the hip or joint replacement becomes a bit less than satisfactory. Aquatic therapy has been shown to have multiple beneficial effects. The reason being is that it takes the weight off the joint and allows the patient to move. And motion is what helps produce synovial fluid, strengthen the muscles, and keep the patient well conditioned. Walking aids, a cane or crutch in the contralateral hand is always very helpful just to decrease that the joint reaction forces, and also take away the limp that patients typically have with hip osteoarthritis. So it's always something you can suggest to patients who don't want to go for surgery immediately. Medical therapy is always our first line after exercise and weight loss. And we're lucky that we have a lot more recent advances in the use of non-steroidal anti-inflammatories. So we had previously the COX-1 inhibitors, ibuprofen, diclofenac, and then we've got now the COX-2 inhibitors such as Celebrex and Arcoxia. And you just got to balance it out with your patient in terms of what is the GIT versus the cardiovascular risk, right? I generally like to use Celebrex and 200 milligrams BD for 5 days and then taper them down to 200 milligrams daily. And that seems to have, that is my first line. It seems to have a good effect. Acetaminophen, I don't think we commonly use it in South Africa. I think this is more just from the American guidelines. We tend to use paracetamol. But important to add paracetamol to the non-steroidal anti-inflammatories because they have a synergistic effect. A lot of patients come in and ask about these osteo-E's and other glucosamine and chondroitin sulfate formulations. So basically what they are, they're precursors to glycosaminoglycans, which are found in articular cartilage. How they influence the joint when taken orally, we're not really sure, but they thought positively affect the structure of articular cartilage. There was a recent 2017 systematic review. They weren't really able to demonstrate sufficient evidence to support their use in osteoarthritis. So I don't particularly recommend it to patients if they want to get it. I don't stop them from getting it, but it's not suggested, especially if patients have to pay out of pocket for these things. You want to make them spend money on something that's not necessarily going to help them, or we're not sure how it's going to help them. Intra-articular steroids and or combined with local anesthetics can give short-term relief. There's always the risk of infection because now you're introducing a needle and substance into the joint. Best generally done under fluoroscopy because the hip is a very deep joint and useful in combination as a diagnostic tool. So what I mean by this is that sometimes patients present with a spectrum of pathologies or multiple pathologies, and we're not 100% sure what the main pain driver is, whether it's coming from the hip, whether it's coming from the knee, whether it's coming from the back. and an injection of local anesthetic into the joint, the hip joint, under fluoroscopy typically, is a good diagnostic tool. So we know if the pain goes away, that the main pain driver is the hip, and then the patient will probably do better with a total joint replacement. But if it doesn't take away the pain, then we need to kind of look elsewhere as to where the pain is coming from. Viscose supplementation, we'll talk a little bit more about later on the knee osteoarthritis, because it's typically used in the knee. It's not approved by the FDA for the hip, so we don't use it in the hip. We'll talk a bit more about complications later. PRP, or platelet-rich plasma. So this is where you take the patient's blood and you centrifuge it, and that's thought to give you a concentration of growth factors. There is a significant cost, and there is variability in processing it. Different companies and different hospitals and different practices do it differently. Insufficient data at this point to recommend the use in the hip. There are alternative treatments, and I always encourage patients who don't want to undergo surgery, who may not be at that bone-on-bone level where we would consider surgery. And this is acupuncture, massage therapy, manipulation, spa therapy, whatever the case may be. There's a lot of things which patients like to explore, and sometimes they get relief. I don't ever discourage patients from trying different things, provided that they don't spend an inordinate amount of money on these things. In terms of surgery, not much has changed in terms of what we do. Arthroplasty is still the standard of treatment for end-stage osteoarthritis. How we do the hip replacements, the materials that we use, the metals that we use, the bearing surfaces, that has changed quite a bit, and I'll touch on that a bit later. In terms of arthrodesis, occasionally you have patients asking about it, and it's basically something that's outdated. We don't really look at doing arthrodesis anymore. It's something that's largely sort of in the history books. Naren, I'm just not sure about the blue writing. I'm going to stop sharing, and then I'm going to start sharing again just to see if it goes away.
Sure, no problem. Thanks.
Yeah. Okay, that's a bit better. Okay, so treatment of knee osteoarthritis, right? So the prevalence ranges from radiographic to clinical, and it's more prevalent in women than males. And a very large percentage of patients will present with symptomatic knee osteoarthritis throughout their life, 44.7%. We know it's high in females. We know there's a strong relationship between obesity and osteoarthritis of the knee. We're beginning to understand a bit more about limb alignment, either congenital or post-traumatic, and how that affects the knee. Because if your knee is malaligned, you're going to develop abnormal contact forces in the knee, and that can develop severe osteoarthritis. Like I said, in South Africa, our demographic is a bit different from other countries. We have a lot of trauma, either fractures, meniscus injuries, ligament injuries, and this can lead to osteoarthritis. So almost always does lead to osteoarthritis in the sense of ligament injuries, instability, and meniscal injuries. Intra-articular fractures, provided the meniscus is well maintained, doesn't usually lead to osteoarthritis. Inflammatory arthritis, I remember, when we started clinical work many years ago, we saw a lot more patients with inflammatory arthritis. We still do see them in our arthroplasty units, but I think with the advent of better medical therapies, we don't see them as much. Infection is still a big thing for us in terms of in South Africa. We see a lot of it, joint infections, both bacterial and mycobacterial, and that leads to osteoarthritis down the line. And then metabolic disease is something that you also have to keep in mind. And here again, we take our cue from the AOS clinical practice guideline. And we first generally start with non-surgical and surgical. But just to mention something, we have this ladder of treatment, right? Non-surgical and surgical. But if I see patients with end-stage arthritis, I don't start with non-surgical. I go straight and offer them surgery if they have grade 4 osteoarthritis. You don't necessarily always have to start with these things to see. It's more the patients who have grade 1, 2, and sometimes maybe 3, or patients who are not yet ready for surgery because of personal reasons or because of medical conditions they need optimized, that you can look at the non-surgical options. There's nothing wrong with offering a patient surgical intervention without necessarily going through the rest of the ladder. So here again, weight loss and exercise, low impact aerobic activity, neuromuscular education certainly improves pain and function, and also improves the outcome of our knee arthroplasties. I always tell patients that, a knee replacement, more so than a hip replacement, is a contract between me and you, right? I do 50% of the work in terms of putting in the knee. You do 50% of the work with the physiotherapist in terms of making the knee work, right? And the other thing I tell them is that a knee replacement is like buying a car, right? If you want the car to run well, you need to service the car. You service the car through exercise and physiotherapy. And we know that BMI less more than 25 should try and be addressed, but we know for sure that BMI is above 35 for patients going knee replacements generally have a higher complication profile. So orthoses, typically I never use them a lot locally. In Canada, I saw a lot of patients who actually would benefit from this. And it's typically your, well, on that side is your ice hockey players who don't want to give up playing ice hockey. So they strap their legs up in this. So basically what it does is that if you've got medial compartment osteoarthritis, you wear a valgus loading or valgus directing brace. So that basically offloads the affected compartment. So technically you have less pain and less grinding of that bone on the bone. And it's typically obviously in patients who have only one compartment affected, because if you have more than one compartment affected, as you distract the one side, you're going to compress the other side. So if you have one compartment affected, you can try and avoid contact in that compartment. And typically also in patients who want to delay surgery, you can give them a try with a brace and see how it goes. And the main aim of this is to try and improve function by reducing symptoms. It doesn't alter the course of the disease as such. It's just for patients who want to stay very active or patients who want to delay surgery. Here again, medical therapies that we've discussed before were first line. The next thing, the knee is a relatively superficial joint, so it's easily accessible to us, especially in our consulting rooms. And I know my experience is that patients tend to, the first thing they ask is, can't you just put an injection into the joint? So I thought I'd cover a bit about corticosteroid injections. There was a good review article recently about corticosteroid injections, and what they thought to do is decrease inflammation in the joint and also help with pain. And I always put a bit of local anesthetic in as well, because the steroid generally takes about 3 days to work. The local anesthetic works immediately, especially if you've got a mix of marcaine and lignocaine. You get that immediate relief. It's also diagnostic in a sense, and it gives some time for the corticosteroid to work. And the question you always ask is, which one should you use, right? So there's no real evidence to say you should use one or the other. It's usually based on habit, or more often than not, what's available. I generally use Celestone Soluspan. It's what the hospitals that I worked in, what they had. Triamcinolone hexacetonamide, that's the one who's thought to be more effective. No real proof behind it. But the reason is they thought that, because it's less soluble, it stays in the synovium in the joint longer. However, just sort of anecdotally, the things aren't exactly, what's the word? They do have effects down the line, especially when you do joint replacement. You can actually see in the joint which joints were injected, because they tend to leave some sort of residue in the joint. But nonetheless, they still do help patients. The good thing is, like I said, when you provide it with local anesthetic, it does give you that immediate relief. But just beware of the ones that may crystallize when mixed. So you've got to know which one you're using. And there's always a risk of chondrolysis in the long term. But we know that, for every injection, you may lose about 1 millimeter of cartilage. But in the long term, if a patient knows they're going to go for a joint replacement at some point later in their life, just getting some short-term pain is really a small, I don't think it's a big issue. And then people always ask, so where do you inject, right? So sometimes can be a bit daunting. So this is how I started off injecting joints back when I was an intern. The knee and extension, and I used to use a super lateral site. The problem is, you're not sure about the anatomy of the patella, and sometimes you get underneath the patella. Sometimes, you're not sure if you hit the patella. Can cause pain to the patient. But it's one of the ways that's described. Recently, I started using this approach also because I do some, not a lot, but I do some knee arthroscopies as well, and use your anteromedial and your anterolateral portal. So basically, with the knee flexed, exactly where you see those dots, lateral and medial to the patella tendon, it's a very easy way of getting into the joint, and you can do it with the patient sitting or lying down with the leg on the side of the bed. And very easily accessible. You can get a needle in there, you can inject some local anesthetic, you can change syringes. it's a lot more pleasant for myself, and it's a lot more pleasant for the patients as well. Obviously, with injecting any joint, your biggest worry is, are you going to introduce infection to the joint? So always follow strict aseptic techniques and know which product you're using to clean the skin. So generally for chlorhexidine, it's contact time, right? So you want 30 seconds at least for it to dry, for it to actually work. Povidone iodine takes about 1.5 to 2 minutes. So it just depends how much time you have. The no-touch technique is a very nice technique, is where you clean the skin, you prepare the syringe, and without actually touching the skin again, you use a sterile syringe. So that sort of negates the need for you to have a sterile tray or to have sterile gloves in your rooms. Just clean the skin, make sure you prepare everything, and without even touching, you just inject it. That's what I generally do. So frequency of injections, try not to give more than 3 to 4 per year. There's no real sort of maximal number of lifetime injections we know of. And we know that, with time, these things tend to have less effect. And the longer you use them, they don't really have the less effect they have. There are a number of contraindications, and the main things are, if there's any compromise to the skin, the bone, or clotting, or the presence of a joint prosthesis, don't inject the joint, especially if the patient has, it's labile or brittle diabetes. You don't want to inject that joint. And you also need to discuss complications, possible complications of the patient. And these can range from skin pigmentation, atrophy of the skin, residual injection site pain. So the pain in the joint might be gone, but they might have injection site pain. Steroids can give facial flushing, endocrine issues, increase in blood pressure. Biggest thing I always tell patients is the risk of infection or septic arthritis, which then you're really going to need surgery. And then direct entry to the cartilage with the needle. Or hopefully with techniques we use nowadays, we don't really injure the cartilage. And this is important, is that steroid injections and surgery. So we used to say that if you're going for surgery, you shouldn't have an injection into the knee for at least 3 months, right? But there's now studies showing that where you should actually wait between 6 and 9 months. So patients who have had an injection into the knee within 6 and 9 months of a total knee arthroplasty, or even an arthroscopy, have shown an increased risk of infection. I know some surgeons even wait a year after an injection. So just be careful before injecting a joint, that this patient is aware that they're going to be unable to go surgery on the joint or total knee arthroplasty on the joint for some time if they get an injection into the joint. So viscosupplementation, also another injection you can use into the joint. And what basically is, it's hyaluronic acid, similar to synovial fluid. And what it's thought to do is provide shock absorptive and contraprotective and anti-inflammatory effects. And it has been shown to have some symptomatic relief of pain. However, not all of these products are the same. So you need to understand which products you're using. So a recent systematic review, meta-analysis looked at this. I looked at the different products. So you have the high molecular weight and the more low molecular weight ones. And you get those derived from animals, the avian derived ones, and you have the biological fermentation ones. So the studies are out currently support the high molecular weight ones and the biologically produced ones. So the one that we commonly use in South Africa is Synvisc, and now recently they come up with Synvisc 1 because it's a 1 injection, with the previous one with 2 to 3 injections. Overseas, what's really coming to the fore is Durolane. So Durolane is also very good. I've seen many patients, receive repeated Durolane injections and do fairly well. But the biggest thing with this is to choose your patients correctly, right? So you don't want to inject this in a patient with grade 3 or grade 4 osteoarthritis. The moment patients has obliteration of the joint space and osteophytes and all of that, these things don't work and are just a waste of money and actually can be more detrimental to the patient, right? So these are patients with mild to moderate osteoarthritis, so not candidates for total knee arthroplasty, right? Again, you want to follow an aseptic technique. We're not 100% sure about how many injections you can give these patients, but generally about every 3 to 6 months is relatively safe. And the potential adverse effects are similar to a corticosteroid and can be also very product specific. So just check whichever product you're using, what the potential side effects are. Platelet-rich plasma, as I mentioned before, it's probably more routinely used in the knee than in the hip. And we've discussed how we make it. Various companies can come to your rooms and help you to make PRP. And these growth factors are thought to have chondrogenic, MSC proliferation, anti-inflammatory effects in the knee. Very limited evidence, but there is some evidence in the systematic review of quoted where it does have some examples. So I am going to look at incorporating this into my practice. So next I want to discuss, similar to what I discussed at the beginning, in terms of how do we maintain the knee in young adults, because we know that patients less than 55 with knee replacements generally don't do well, generally require revision in 5 to 10 years. So we've been looking at how we can not only alter the course of the disease, but maybe provide an alternative that patients maybe won't require an arthroplasty. And this is a very beautiful, elegant way of demonstrating our current approach to osteoarthritis of the knee. So obviously my niche sits sort of in the middle here in terms of osteotomies, a unicompartmental, we just replace one compartment of the knee and total knee arthroplasty. And then obviously the complications that can occur, they have either revisions and everything leading from arthrodesis to amputation. But it's important to understand everything before that is all part of the same spectrum. So whether it's arthroscopic surgery to repair an ACL or to repair a meniscus, or overseas, some people locally are doing meniscal transplants, taking cadaveric meniscus from a cadaver and putting them into the knee, whether it's putting on a brace. This is all part of the same spectrum of treatment for these patients. It's important to view ourselves as the orthopedic surgeons, as well as yourselves, as the physiotherapists and the general and family practitioners, as we're all part of the same spectrum, and we all try to treat the same things. And so the only way we can combat this pandemic is by working as a team. But it's important to understand what the options are and when we should refer and what the option, or when is the right time to do that. So I thought I'd demonstrate was the case. So this is a 39-year-old female. She presented to us with progressive pain and deformity in the right knee, both in the anterior, medial, and the lateral side. We tried a brace, we've tried physiotherapy, and she's now at the end of her conservative management, and she requires surgery. But she's 39. We don't want to do a total knee arthroplasty on her. There's nothing that we can treat her in terms of an arthroscopy or anything else. But clinically, she's got quite severe valgus alignment, more on the right than the left. We're not sure about a rotational deformity because the valgus can mimic a rotational deformity. Her foot progression angle is normal with the knee flex, so that kind of makes us think less of a rotational deformity. So the valgus deformity is partially correctable. So when we pull the knee into a varus, there's a bit less valgus, but it's still in valgus. There's no lateral joint capitis and there's no patellar tracking, right? So this is an X-ray of this patient. So this is a full-length standing X-ray. You can see quite severe valgus deformity, and she's got early osteoarthritis of the lateral compartment of the knee, and her patella seems to be tracking relatively okay. So the question is, what do you do, right? So the first thing is her femur, is her tibia aligned? So the first thing you do is draw what you call your medial lateral distal tibial angle and your medial proximal tibial angle. So typically these should be 87. And how these are drawn is you draw a line from the center of the femoral head to the center of the knee and then across the joint line, right? And that angle should be 87, right? The moment that this angle on the lateral side becomes less than 87, that femur is termed as being in valgus. The moment this becomes more than 87 degrees, that tibia is termed as being in valgus. So the red numbers mean that these limbs are both in valgus, right? So the question is, how do we realign this limb, right? So the easiest thing to do, well, not so technically easy, but we want to realign this limb. We need to take out a wedge of bone as demonstrated by this white triangle. We want to remove that bone and try and get the limb straight, because once the limb is straight, it takes the pressure off the lateral compartment and the patient has a mechanically aligned limb, and we can hopefully stem the tide in terms of the osteoarthritic cascade, right? But if we do that, we're going to have a very varus femur. So we replan again. We say, okay, fine, we'll take a wedge out of the femur and we'll take a wedge out of the tibia, and both of them together give us a relatively straight limb. So we took this patient to theater, we executed that, and this is sort of the modern techniques in what's called high tibial osteotomy, or distal femoral osteotomy, is where we realign the limb to offload the compartment. But this can only be done if the limb does have actually some malalignment, which is why we draw the angles and try and carefully calculate, to the millimeter, how much how many millimeters of bone we need to remove in order to realign this limb. And these plates are very, very specific plates designed for osteotomy. There's a lot of research and R&D that went into this. And this is the thinking, is how we can alter the course and preserve joints in young patients with knee osteoarthritis. And so we can do this in patients with varus knees, valgus knees, depending on where it is. And we can use a combination of either just on the tibia, either just on the femur, or both, to try and achieve our objectives of a mechanically aligned limb and decreasing the weight on certain compartments. This is just a nice summary or flow chart in terms of management of osteoarthritis of the knee. I can share this with you later if you need be. Quickly on part 2, I know I'm sure everybody is a bit tired, but I want to discuss about what's happening in terms of the evolving model of care in arthroplasty and the modern approaches. And this is not something that's unique to the South African private sector. It's also in the public sector, and it's also something that's sort of becoming the standard of care overseas, right? So we're moving towards more of a value-based system of care, right? Where we economically conscious members of the team, right? We're focusing on early recovery of patients. So previously, joint replacement patients would be in hospital for about 2 weeks, then it became 5 days, then it became 3 days, then it became 2 days. And now there's many centers around the US, Canada, as well as in Europe, which are now doing outpatient arthroplasty. So basically what that means, the patient comes in the morning, they have a joint replacement, they recover for 6 hours, they see the physiotherapist, and they're home and sleeping in their own bed the same night. And that requires a massive system of, in terms of a center, in terms of manpower, in terms of expertise. But I definitely think in South Africa, with the quality of our healthcare workers, we can definitely achieve something of that level. But this is the way we're moving. We want to keep patients out of hospital, especially with COVID flying around everywhere else. We want to decrease patient contact time in healthcare facilities. We want to make them recover early. So that requires a lot of effort on our part in terms of how we conduct our surgery, how we cover our patients, how we counsel our patients, how we address their expectations. And what this also requires is continuous monitoring and optimizing of our outcome measures. So we need to actually evaluate how we're doing. We need to evaluate how long we operate for, how long we keep patients in hospital for. We need to evaluate patient outcome scores. Are patients happy with our surgery? Is it working? What is our readmission rate? What is our complication rate? This is the only way we're going to get better. And this is the way that arthroplasty is moving. So this is just a picture of the Discovery Arthroplasty Network, which I've become a part of. And this is just a summary. Basically, like I said, it's a value-based care. It's a multidisciplinary team. I think that's very important to understand, is that this is not something that surgeons can achieve by themselves. It can only come to fruition once you have a team of people. So everybody from the anesthetists to the surgeons, to the prosthetists, physios, the family practitioners, the hospitals, and what medications we use in terms of achieving these optimal outcomes for arthroplasty patients. And I love this picture because this is how I see arthroplasty surgery. It's it's every member of the team doing their part to make sure that our driver and the patient in their joint, who is the driver, is working optimally. That we all do our part and we do it efficiently and we do it sort of repeatedly in a reproducible manner. Another way of looking at it is an orchestra. Is that when patient comes for arthroplasty, we have a set sort of routine which we follow, and that makes it more reproducible and makes it easier to measure our outcomes. So, like, all in all, it's about the holistic care of the patient. So, making sure we optimize these patients preoperatively, we prehab these patients with physiotherapy.
I have one for you.
Oh, can I see
I
mine?
have somewhere. Look for it.
Okay.
Sorry, Bro, but I think we muted you mistakenly. You can just unmute yourself.
Okay, I think that's better.
Thanks.
So we have enhanced anesthetic techniques where we use mostly regional anesthesia and block, and that allows us to recover our patients early and mobilize them a lot quicker. We're also using less drains and catheters, etc., because we use drugs which help us stop bleeding. We encourage patients to get up and go to the toilet by themselves instead of having catheters which keep them in bed. Other blood management strategies is hypotensive anesthesia, so we prevent patients from bleeding too much intraoperatively. And we use tourniquet-less surgery in total knee arthroplasty. We know that the blood loss, whether you put a tourniquet on or not, is pretty much the same. Sometimes it's higher when you use a tourniquet, but we'd rather have that blood sort of bleed in theater as opposed to bleeding into the knee post-operatively, because that what causes the swelling, the pain, and prevents the patient's motion post-operatively. Tranexamic acid has something that's revolutionized orthopedic surgery from trauma to arthroplasty. Basically, what it does is, it's used commonly in gynecology, but prevents the existing blood clots from breaking down to fibrinolysis. There's a lot of talk in the orthopedic fraternity with regards to surgical approaches to the hip. I think the topic which evokes the most amount of emotion and debate is the direct anterior approach for hip replacement. Basically, what it is, it's a muscle sparing approach. We use muscle planes to access the hip from the front to perform the hip replacement without actually detaching any muscles. And this has been proven in meta-analysis and systematic reviews to lessen the amount of pain that patients have post-operatively, and also to reduce the risk of dislocation hip replacements. And obviously, it earned a bad reputation many years ago because it is an extremely demanding approach for the surgeon. It can be very difficult. But now we have dedicated instruments, we have tables, we have drapes dedicated to achieving this. And just as we speak this week at Tigerberg, where I trained as well, we have the direct anterior approach training course. I myself and our fraternity, we strongly believe in the use of the direct anterior approach for surgery, and I try and use it for most patients. But I do tell patients that there are certain indications where I wouldn't use it because I think it's just not worth the risks. But this is where surgery is moving, is that we do less damage to the soft tissues in the hope that patients will recover quicker. And the longer I do orthopedic surgery, the longer I realize that it's less about bone surgery. It's more actually soft tissue surgery. With the bone.
Dr. Faisal said I was writing minutes here. I just wanted to.
The other things that have become quite buzzwords in arthroplasty is robotics. So basically what robotics does is you do a CT scan of the patient's knee or hip preoperatively, you input that into the robot, it gives you a surgical plan, and then as you perform the surgery, the robot assists you in making the cuts. Certainly it's much more accurate in terms of doing cuts freehand or with jigs. We still need a lot more studies and time to figure out whether it actually improves outcomes in the future. Moving on even more advanced, and that is what's called augmented reality. So basically a surgeon wears a pair of virtual reality glasses during surgery, and you can see real-time ligament tension, real-time where he's making his cuts before he actually makes them, and try and make him a bit more of an accurate surgeon. We have 3D printing, where we can take a CT scan of a patient's bone. We can 3D print that sort of overnight in certain labs in South Africa. And then from there, we can decide on what type of implant we can use. Even more than that, sometimes, for very complex cases, we can actually make custom 3D printed implant to fit onto that patient's bone. This is becoming routine in some areas of Europe, where they do a CT scan of the patient's knee or hip. That CT scan is sent to Switzerland, where there's a team of about 50 biomedical engineers who design a cutting guide for that person's specific knee. And then it's packaged everything with the 3D printed joint to you in about 2 weeks' time. And then for you to perform that surgery on that specific patient. And what's nice about it is that you don't have to autoclave any sets. It comes everything in one box and you dispose of that. So my first thought to them was like, well, what about the environmental impact? So they are offsetting their impact through other environmental projects, while we save water on actually autoclaving. So there's a lot happening. Every day there's something new coming out. I think it's important to realize that at the end of the day, that no matter how fancy the toys are, no matter how advanced the technology gets, it's only as good as the surgeon, holding that in his hand. So it doesn't make a bad surgeon a good surgeon. It makes a good surgeon certainly a great surgeon. So in summary, my message is that osteoarthritis is a systemic condition. It doesn't just affect the joint, it affects the human being. cardiovascular system, it affects their diabetes. It is certainly growing, it is certainly costly, and we need to be aware of that. Prevention and early detection is really important for us to be aware of, to have a high index of suspicion, to pick up patients who may have these conditions. There certainly are options for younger patients who are not amenable to arthroplasty, who have conditions still amenable to joint preservation. The way we conduct joint replacement is evolving, and this is all with the idea of optimizing patient outcomes and also optimizing the economics of arthroplasty and the financial models used in arthroplasty. Technology is here to stay. Slowly but surely, it's going to find out its way into the everyday use. And it's all in our quest to create the forgotten joint. So every arthroplasty surgeon sort of spends their life trying to achieve what's called the forgotten joint. And what that means is that we try and create a joint that's so good, that functions so well, that the patient forgets that they have a joint replacement. And that's what we want to work towards. And for that, it doesn't just require us as surgeons, it requires us, all of us here, sitting as a team to try and address our patients. And lastly, as I mentioned at the very beginning, movement is life. And keeping our patients moving is what keeps them alive and what keeps us alive. Thank you.
Thanks, Mohammed. That was an excellent and well-planned presentation, and I think we all loved your illustrations and case studies as well, and your personal experiences with this. And I think it's also important to mention, as you said as well, the multidisciplinary approach with regards to this. So with your physiotherapist, your family practitioner, and yourself, the orthopedic as well. And you made a very good point in the beginning, which is an eye-opener for us as well, that we should not deny patients arthroplasty based on the fact that they might have uncontrolled diabetes or hypertension, because those very same conditions can lead to immobility and cause them, in a way. So thanks for that. We've got a few questions. If there's any further questions, you can post it in the chat box as well. The first one, what is your opinion on the platelet-rich plasma injections? Do you find it beneficial to patients? Is it comparable to steroid injections? Is it just a way of buying time before a replacement?
Yeah, absolutely. I think there's certainly a place for it. I think, I put myself into that position. If I or family member were told, like, you need a joint replacement, I think knowing what a joint replacement entails, especially in the knee, I know what a big procedure it is. So I would first try and exhaust all conservative measures first. So I definitely think there's a place for PRP. In terms of the quality of the PRP and how it's processed, I think we need more studies. And I think it's important for us to we all in private practice, or most of us in private practice. But I think to some degree we should try and keep records. Maybe publish our results and see what works, because right now we don't know. We know that it does work, but we're unsure as to how it works and what's the best way of doing it. So, but I think we all can contribute to that body of knowledge by sharing our results with each other. And I certainly am, in the coming weeks, going to incorporate it into my my practice.
Thanks. The other question is, there's a recent increase in collagen supplements advertised as improving joint health. Can you comment on this?
Yeah, so like the most recent review didn't find any benefit to it, right? So in terms of using that as a treatment, I wouldn't encourage patients to spend their money on it. However, if a patient wants to use it and they find anecdotally that it helps them, I don't discourage them from using it. But I certainly wouldn't prescribe it, and I certainly wouldn't encourage it if a patient never brought it up. But that's purely based on the paper,
Mm-hmm. That's true. Patients spend thousands of rands per annum on these supplements and nutraceuticals as well. If you look at the cost of these hyaluronic injections like Suplacin and Synvisc, You know, they range to the thousands. I think the cost of the injection is probably around 3,000 rands here, and that excludes the consultation and fee for injection and things like that. It'll probably be better if patients save up and have one of those injections rather than spending so much on supplementation.
Especially patients who are candidates for it, like the mild and moderate arthritis who still have joint space. Definitely, I would rather say, you know, save up your money if you're going to spend money. Rather, let's do a Sinvasquan, let's do a Durolane, and that has some evidence behind it, right? And that's something tangible that you're putting into the joint. You know how that, you know, the supplements are going to be absorbed and find their way to the joint. I don't know. I don't. And I can't really comment. But like I said, what the studies are saying is that it doesn't show any tangible benefit, and I wouldn't encourage people to spend money on that if they can't.
What's the maximum dose of celestone, for example, that you would inject into a knee joint? Will you go more than 1 ml, or depending on the weight of the patient?
I generally don't go more than 1 ml. Also because I generally mix it with about, say, 4 or 5 ml of lignocaine plus 4 or 5 ml of marcaine. So I think more than that is a bit of a push. But I try and space them out. So I'll give the patient about 3-4 months, and if they really want another one, I'll do another one. But I have a long chat with my patients about the risks of infection, mainly because that for me is like, whenever I do one, it's like the biggest fear. I won't sleep that night. The second thing is that I tell them, like, you know, if you decide to undergo surgery, there's going to be a period of about 6 months or so where you're going to be in severe pain, and I can't do anything for you, but I need to wait that period to do a safe joint replacement. I think so. Just the counseling, yeah, about that. But yeah, I usually go 1 ml celestone. I don't usually go more than that.
Okay. And are patients with SUFI more prone to degeneration of the hip as they get older?
Absolutely. So they're more prone to femoroacetabular impingement because of the shape of the head. It sort of simulates a cam lesion. So they get impingement, and overall they have definitely a increased risk of osteoarthritis. We do see them, especially in the public hospitals, coming with a very young age with degenerative hips. Also, just you know, you're talking about young patients. You know, before we would tell young patients, okay, you know, wait till you're 50, wait till you're 55, wait till you're 65, then we'll do a joint replacement. And I think that is criminal to do that nowadays. I think with the advances we have in the plastics and the ceramics that we're using in joint replacements, we can do joint replacement at any age. We are trained in Tigerberg. We actually have a series of, I think, over 20 patients, under 20, where we've done joint replacements. And if you really think about what you're asking a patient with severe pain and disability to wait before they can enjoy their life when they're 65. It doesn't make sense. We'd rather say take the risk now, right? Have the surgery, but at least have a good 10 to 15 years. You know, if you need a revision later on, we can deal with that then. But we should not be discouraging young patients from joint replacement if they qualify for joint replacement, because we have evidence now, both in South Africa, both in the UK, that even children under 20, and these are generally kids with cerebral palsy, SUFIs, with severe DDH, etc., who had previous surgeries or even trauma and infection, who are very disabled. And you know, we've seen these kids come into the hospital at Tigerberg, and very often sort of north of our borders from other African countries. Severe deformity, they're wasted, they've got malnutrition, they're very sort of reclusive emotionally, they don't know how to interact with people. We do joint replacements for them. 6 months down the line, they're almost like a normal child. So, you know, I get upset when I hear that patients were refused joint replacement based on their age.
And I suppose that will go the same for AVN of the hip. Would you, I suppose you wouldn't want to delay that as well, because it is a progressive disorder.
So, I mean, AVN, you know, if it's grade stage 1 or 2 where the head is pre-collapse, I would always try and preserve the joint. So I would do a core drill and wait and see, ask the patient to non-weight bear or treat them conservatively. The moment you have collapse of that head, then, you know, your options are very slim. There are some centers which will consider an osteotomy of the femur, so but they'll cut the femur and then redirect the femoral head. But that's very specific indications, a very young patient, and also a patient with a very small lesion where there's enough remaining femoral head for them to have articular surface. But Yeah, you're correct. I mean, once there's subchondral collapse, I think for me, the most reliable operation would be a total arthroplasty if the patient is not responding to conservative measures.
Thanks. There's another question in the chat. Are there any recommendations in preventing a patient with osteopenia from progressing to osteoporosis? And on that note as well, will you offer a patient with severe osteoporosis an arthroplasty?
Yeah, look, I mean, if they have degenerative joint disease, I would offer them. I mean, we do hundreds, thousands of hip replacements for patients with hip fractures. It's very unusual to have osteopenia and osteoporosis in the same patient, but I don't think that would be a contraindication to surgery. In that case, I would probably opt for better bone fixation with a cemented implant, but I wouldn't term it a contraindication. I would still offer that patient surgery if they qualify for surgery. In terms of osteopenia, preventing osteoporosis without use of bisphosphonates, there are many other options. In terms of the medical treatment of osteoporosis, I tend to generally refer my patients to an endocrinologist. But as far as I know, bisphosphonates are still the standard of care for osteoporosis. The other thing is that, like I said, life is motion, and the more exercise that we do, the more resistance training that we encourage patients to do, the stronger their bones get. So again, I would refer the patient to a physiotherapist because I think a lot of patients don't know how to move. They don't know what exercises to do. And the physiotherapist can actually help in terms of introducing patients to resistance exercises, right? So instead of only aerobic, we can also do resistance exercise because that's what tenses your muscle. And when you stress your muscle, you stress your bone. When you stress your bone, the bones get stronger.
Yeah. But with regards to the types of prosthesis, how do you decide what to use, whether it's titanium, chromium, or ceramic?
So there's different parts to the prosthesis. In terms of the femoral, okay, let's talk about hips first. In terms of the femoral stems, we've largely moved to titanium simply because the stiffness of the titanium is similar to that of bone, right? And what that means is that there's better integration of the metal to the bone. So if you take something like cobalt chrome stems, they're very stiff. So what they tend to do is take the load from the bone and the bone becomes weak and then you get fractures. So titanium is a much better material, and we have coatings on the titanium ranging from hydroxyapatite to porous coating, which help to integrate the bone in. In terms of, and that goes for the cup side as well, they basically all titanium now, and now you have even 3D printed porous coating, and what the porous coating helps assist in getting the bone to ingrow onto the prosthesis. In terms of the bearing surfaces, so the actual surfaces move onto each other, we generally put a head on the femoral prosthesis and then liner into the acetabular part. In South Africa, I think most surgeons will use a polyethylene liner, because it's a very highly cross-linked or very advanced plastic. The worry with plastics historically was the wear. So as you walked on the hip, you wear out these plastic particles. These plastic particles get into the joint, they get into the bone, they eat up the bone, and the prosthesis become loose. But because these plastics have become so advanced, we don't have those problems anymore. So most people use plastics. In terms of the heads, we've moved away a lot from cobalt chrome and moved to ceramic, simply because with the cobalt chrome, it's a lot harder and they tend to wear out the plastic quicker. The ceramic does that a lot slower. The other thing is that the junction between the neck of the femoral prosthesis and the head, when you use cobalt chrome, that area can release metal ions, and that can cause metal reactions in the joint, and we want to prevent those. So the standard at the moment is generally a ceramic on polyethylene with bearing surfaces with titanium metal implants.
Thanks. Roughly what's the duration for a hip for surgery for a hip or knee replacement?
I would say on average about 60 to 90 minutes for either or. I mean, you have some cases which take you a lot quicker, will take you about 30 to 45 minutes. Sometimes you have a very complex case that might take you about 2 to 3 hours. But I would say on average 60 to 90 minutes.
Excellent. Thanks. Let me just quickly go through the chat. Okay. Yeah, I think you've answered all our questions quite comprehensively, Mohammed. And there's lots of tributes and thanks to you as well in the chat. And really appreciate the time you've taken to prepare the talk and for your experiences in keeping us up to date with the advancements in hip and knee osteoarthritis currently as well. And on behalf of Abnul Qadi Hospital and myself and Standard Bank, thank you once again for giving us such an excellent presentation. And we'll definitely be expecting more as well. Yeah. Yeah, you can. Yeah, I think someone wants to ask a question. Yeah, you can go ahead.
Yeah, Dr. Good, Mohammed.
Yes, Deva, go ahead. Sure.
Hi.
Can you hear me?
Yes.
Halfway through, you posted a very interesting X-ray of a patient, 50 years old, what to me initially looked like a pathological cause of that hip joint. Was it 50 years old, overuse of that joint, or was he an active sportsman? Or did a colleague miss the diagnosis? How would you manage a patient like that, 50 years old, both joints completely destroyed? Do you think overactive sportsman in his young days?
Yeah. So that patient was a patient at Tiger Brook Hospital. This African patient that we actually did a hip replacement for him. There's a couple of things. So if you looked at his pelvis, okay, there were signs on his X-ray that his pelvis was very retroverted. What that means is that his pelvis faced backwards. So he had a form of impingement where his femoral neck would keep hitting the front wall of his acetabulum, right? So that's why we think that he developed such severe disease, especially look at the pattern of the disease. So the first sort of red light is that this is a 50-year-old patient, right? He's got bilateral disease. So this is abnormal that for a patient that young to have such severe disease. Looking at that X-ray, he didn't have any significant history of sport or trauma or anything like that. No history of infection, nothing at all. The only thing that we could really pick up was this, he had hip pain from a very young age, and it was sort of, he ignored it, he sought help, he didn't really get treatment, and that's how he ended up, So I think we should try and pick up those patients earlier. That's why I showed that picture, and we want to pick them up earlier. I think he had impingement, and we didn't really understand the disease that far back, and he did, quite severe degeneration. In terms of his surgery, it was a very complex surgery. So the biggest cup that we have on the set was still too small. So we actually had to use like what we call an augment, like a semicircle cup on top of that cup to fill up that space, and then the femoral side was relatively straightforward. So these surgeries in patients, young patients with neglected pathologies, can become extremely complex, very difficult to do. So, like I said, we want to try and create awareness around these conditions so that we kind of get to these patients early and prevent them from having joint. I know it sounds counterintuitive. I'm a joint replacement surgeon, and I'm trying to encourage you not to let patients get to the point of joint replacements, but I think we have enough work on osteoarthritis as it is. These young patients, I think, deserve our attention in terms of preventing severe joint disease.
Excellent.
A very short question. Would you discourage sport like squash as we're getting older now, because that's a very active sport, and you have no pathology in your joints? Over 50, squash, which is very active, and take it easy.
Yeah, I never discourage patients from playing sports, no matter what the sport is. But if you are going to engage in a sport and you are over 50 and you're worried about whether you're fit enough, then I would strongly suggest at least a physiotherapist, even a biokineticist, to assess your muscle strength and your muscle imbalances. And they can help counsel you on how to prevent injury. And I think a lot of these injuries tend to be more about technique and muscle imbalances than they are about the sport themselves. But yeah, look, the reason we exist is to keep people moving and keep people active. And that's why we treat sports injuries, etc. So I would never discourage anybody from playing whatever sport they choose to play.
Thank you very much.
Thanks, Deva. Thanks for those questions. Thanks once again, Mohammed. Colleagues, I think we've had excellent attendance this evening, and I think some had to exit because of load shedding as well, but irrespective, thank you all for attending. From my side, thank you and good night. I'd like to hand over to Sreya Vaizi from Amr Al-Qadi to do the closing. Thanks.
Thank you so much, Dr. Budu, and thank you, Dr. Manjra, and to all the participants for joining us this evening. Just from my side, please ensure that you send me your CPD requirements, your MP numbers or registration numbers, your email addresses and contact information. And please take some time to complete an evaluation form for us. Let us know what you thought of the presentation, the speaker, the connectivity and all of that. It won't take you too long. It's about 4 minutes long. And we appreciate your feedback and participation. Have a good evening. Bye-bye.
Thanks, Raya. Good night, everyone.
Bye.
Good night.